Hello, Changemaker.
Welcome to the Innovation Room.
A place for business leaders,
Change agents and change champions.
anyone who wants to know where digital transformation is taking us,
A place that sparks ideas.
and explores what's really possible with software and technology.
Ready?
Let's see what's happening.
Welcome to the Innovation Room. Today's episode, Future of Medicine with AI, Revolution or Evolution, addresses a critical topic at the intersection of technology and healthcare. The advancements of AI in healthcare presents both challenges and opportunities for all the stakeholders of the sector, from the investors, business leaders, and professional healthcare workers to the patients and their regulators. My guest today is a geek of that space, an expert in cancer research, and we are exploring whether AI presents a disruptive force or a progressive enhancement in healthcare. Our conversation focuses on the strategic implication of AI, examining its role in patient care improvement, as well as organizational efficiency and growth. I am Somayeh, CEO of Geeks. Please join me and Adam Pennycuick, medical oncologist in the Innovation Room, to geek out on AI and the future of medicine. Hi, Adam. Thank you so much for joining me in the Innovation Room and for being here to talk about future of medicine and AI. Shall we start with an introduction about yourself and your very, very interesting background?
Sure. Thanks so much, Somayeh, for the invitation. So my name's Adam Pennycuick. I am a medical oncologist. I work at University College London and spend about half my time in the clinic treating patients mainly with lung cancer. And the other half I spend in the lab, and I work on sort of computational approaches to understanding how cancers start, particularly in the lungs, and what we might do to stop them. And I guess I'm interested in AI, particularly. I wasn't always a doctor. I did a maths degree a long time ago in Warwick, and then I worked in the aerospace engineering sector writing software for a couple of years before I went to medicine. So throughout my career, I've been a pretty serious geek, and I've tried to kind of use mathematical approaches, I suppose, to make a difference in medicine.
Yeah, is that the kind of background you see in medicine? Is it normal?
No, not really. It's quite unusual, and I guess it gives me a bit of a platform to be able to talk to both sides. Talk to the computational side and the clinical side, which is I find quite interesting.
It's a very interesting concept, which I think we will dive deeper into as we talk about the medicine and AI. But having been exposed to multidiscipline will give you a very unique position to be able to first understand the different worlds and then try to bring them together. So I'm very excited to discuss this topic with you. But before we start, we have a tradition to ask our guests to introduce who would they bring to the Innovation Room if they wanted to do some innovation work, innovation projects, and why would they choose those people or that person. It can be real or fiction. We won't judge you for it, but we want to hear why you would choose them.
Sure, it's a great question. So I'm going to use this as a little bit of a plug. So for a few years, I've run a medical education company called Osler, and we named our company. Our company's all about trying to make bedside teaching easier. We named our company after a guy called William Osler, who was a doctor back in the late 19th, early 20th century. He founded Johns Hopkins Medical School in the US. And what he's famous for, what he's really known for, is taking medical teaching from the lecture theatre to the bedside. So before that, people were going and learning all of their medicine from lectures, from textbooks. And after he made the changes that he did, people actually went to see patients, which is just a huge shift. And I guess I think that's the kind of mindset we need in the Innovation Room. We need people who look at what's been done for hundreds or thousands of years and say, do you know what, that's not good enough. We need to do something different, and people who are actually able to deliver on that change.
Yeah.
He also sounds quite fun. He was a bit of a prankster. He used to write kind of fake letters to medical journals about made up conditions and things. So I think he'd be quite fun to work with as well.
Cool. Very interesting. I think we may need to, if you bring him, you might end up getting medical students to math courses before they get into the bedside.
That would be a very good plan, I think.
Going into medicine and AI, and specifically cancer research and AI, it's not a new concept. So probably one of the areas that AI was introduced to a lot earlier than other sectors was medicine and was cancer research. How much you have been exposed to using AI, or how much you have used AI in your work, and how much do you think it has changed, any sort of change, based on the the massive interest in AI after last year's generative AI releases?
In truth, on the clinical side of my work, I'd say there's not a lot that I can see day to day that's really changed, particularly since the advent of generative AI. And I guess that's largely because things move quite slowly. And you've mentioned some things that have been going on more behind the scenes for specific tasks. So I'm involved in lung cancer screening, where we have programs that do lots of CT scans of lots of people. And for a while now, there have been AI tools that will help the radiologist, not replace the radiologist, but help them to say, I think there's a nodule here, I think this one might be a cancer, and help direct us to areas of interest. So there are those kind of quite specific implementations that most doctors won't see unless you're in that very specific area doing that specific task.
So they see the implication of
think-
it, they see the impact of it on their work. They won't necessarily be using it, if that's the
So
correct
you'll see scans coming through with scan reports saying that there's nodules, but you won't necessarily know that the radiologist has been helped to report that. So I think there's a lot of kind of hidden roles like that. Where do we actually see it in practice? So risk prediction is another quite major element within cancer, and some tools that have been around for a little while that I think you'll probably class as AI. I guess they're sort of algorithmic. Would be given a situation like if I see a patient who's had a cancer, they've had it removed, and we have to think about giving chemotherapy to stop it coming back. And so to make that decision, I need to know how likely it is to come back, and also then weigh that against the side effects of our drugs. And there are tools built on large data sets that I think you could probably classify as AI, because they're trying to estimate the risk of relapse in future. And those are something I suppose I do see in clinic. But again, that's my own specialty, that in a very specific context of making that decision, there are some tools that can help. And the broader changes that we have definitely seen over the last few years, general tech changes. So the hospital I work in is using Epic, which is quite a big health record system that is pretty good, because it allows me to get all the patient's notes, it allows me to get all the scans, all the bloods, whatever I want. And it's starting to implement some clinical decision tools. So if, for example, I wanted to, if I made a mistake and I accidentally prescribed, 1,000 milligrams of morphine instead of 10 milligrams of morphine or something like that, it wouldn't let me do that because it has electronic blocks on that. And that's not complicated. Most people wouldn't really think of that as AI, but those are the things, I guess, that we see that make a big difference. So kind of computers starting to get into our clinical workflow and helping us either make decisions or prevent mistakes.
As you said, some of it is a pure, logical algorithm, not necessarily AI, but they are very interlinked. One of the areas that I think we don't, like us, not people who are not very much into the healthcare system, but like how much data or what kind of data as a researcher do you have about a patient? How much of it can you access to actually be able to do something about? And then is it something? So say, for example, you wanted to do a research on the impact of how many, I don't know, cups of coffee people have, and is there any correlation between that and their cancer coming back? Do you have access to that kind? Do we capture that kind of data at the moment?
So generally, I guess there's two ways you might get that data. One would be because you have a trial, and there is quite recently they're emerging very large population-based trials. So if I wanted to answer that question, the place I might look would be the UK Biobank, where they've selected a big cohort of people, kind of 500,000 people or so, and done their genomic sequencing, and then asked them lots of questionnaires. And that's the only place that comes to my mind immediately where I would get coffee consumption data,
Yeah,
right?
yeah.
Because it's something that
But Alice,
population
I
would
was
be.
I was having a chat about this with one of my colleagues before this, and I was like, "But how much? If somebody asked me that, I don't count on how many coffee do I, so I would just give like my perception of how many cups of coffee I have. It wouldn't be accurate, and that would completely,
Yes. And that's going to be a major issue with
jeopardize the.
anything sort of recall wise, right? You're not going to be
Yeah,
sure that you've really got very accurate data on that. Though I guess if you've got 500,000 people, then probably on average it's not too bad. If you've got a big enough data set to look at, then
yeah.
arguably you can make a correlation.
So
But you're right.
I
The
made
data's
that question. I made that question, which is you would argue is not the best of examples of like how many coffees do you have and the correlation of that with cancer, but I asked that because then we have other sets of data, like the ones from our wearables that is personalized, is massive amount of data, but they're being captured by private companies. So I don't know how much you can demand to have access to those, or you know.
Yes. So, well, I'll come back to that in a moment. But the other thing that we do have is registry data, which is quite helpful. So whilst the UK Biobank is a sample of the population, which is quite deeply profiled, we do also have data for very limited things on the whole population. So, for example, I can get access to every cycle of chemotherapy that's been given to every patient in England and Wales. That is something you can get, but I'm not going to know how much coffee they drink, and I'll know about a cancer diagnosis. I'll only know very specific fields that can be pulled out of sort of common health records. So I think it's difficult because it's quite a question specific, depending on what you're trying to do with your AI. It's quite specific what you can actually get at, and of course all of these things that are not easy to access, they all have a lot of hoops you have to jump through to get at. The wearables is interesting, and people are starting to explore that. And there was a lovely example of this I saw at a recent conference where people had used Tesco club card data to try to predict ovarian cancer, with the theory being that women with the early symptoms might buy medications for bloating and reflux, or might even buy different clothes because they're starting to feel a bit more bloated. And that is not to say for anybody listening that if you're bloated then you have ovarian cancer, but they're trying to use those
Yeah.
tools to try and make predictors that work.
And what makes it very,
Mm.
very interesting with AI is that if we just want to use AI for what we can think of, that could be the correlations, and then get the AI to process the data on that. So that's one way, but that's like we are not using AI for its full capacity, which is just give it loads and loads of data, let it work out if there is any. Once it comes up with some sort of correlations, then like as experts you can take that and run like focus samples or focus studies or research on them. Because I think that the big difference between AI and the human brain is the capacity in which and the speed in which the AI can process data that is, to us, doesn't have any relationship. Why would how many cups of coffee or how many glass of water you eat would have any, or any sort of, like, not even that, so like the stuff you were talking about, like what do I buy in Tesco should have any relation to what cancer I might get. So it's that kind of data. So I'm thinking, would it be like as expectation, if I expect that with the AI and the amount of data that now we have on individuals as opposed to like years and years ago, my expectation as a patient would be, well, you have so much data about me, why wouldn't you process them and tell me what might go wrong with me and how we can prevent it? If that's the expectation, is it something that then the medicine sector and then the governments as regulators should be looking into, to force different data collectors to share those data
Yes.
with the medical professionals? who want to do some
Yes,
research.
definitely. So I think maybe a tangible example I've definitely seen is with cancers when we sequence them. So we get all of this data that is, so with a cancer I might sequence maybe 20,000 genes, so a big data set for every individual cancer. And there are cancers then that we use this kind of clustering approach to say, well, which ones are more like other ones and what are the pathways that differentiate cancer A from cancer B? And that has led to some changes where we'll look for specific pathways driving one. So although it may all be a lung cancer, one might respond to drug A and the other one might respond to drug B. So that's been used in the genomic space, and that is in some places starting to enter practice. Doing it more generally can be a little bit trickier because what you run into is, what are you actually trying to do? Because I guess that the healthcare system that we have is quite reactive a lot of the time. It's like, oh, you've come in with a cancer or a broken leg or whatever it is, and we've got to fix it. And what you're getting at is you want to be healthier. Well, I mean, what does that mean? Like, does it mean you want to run faster? Does it mean you want to live longer? I mean, what do we optimize for? And that I don't think we've really quite got that approach yet. I haven't seen many people trying to do that with these bigger data sets.
It's a very interesting point you make, because when we look at the future of a sector with AI, we follow a framework called Dare or Die Bullseye. And it's a bullseye that starts with the expectation of the stakeholders, and then the inner layer is the constraint that sector has in engagement with AI, and then the third layer is the offering of the businesses within that sector. What problems basically they want to solve? Is that problem going to exist in the future, or the shape of the problem is going to change? So they need to change their offering. And then at the core of it, the bullseye is the role of human within that offering. So if we just take that framework and think about, if our expectation is changing, that I no longer it is good enough to cure me, to find out that I have cancer and then try to cure it. My expectation is, no, I want you to predict it is going to happen and tell me how you're going to prevent it from happening, not only just look for it when it has happened and I've got lots of symptoms. So if that's the expectation, and our constraint is that, well, yes, we have loads and loads of data everywhere in the world about individuals, their behaviors, and it's not just their medical data we want to be interested in, it's their behavioral data that is valuable as well. One constraint is that, well, we don't have access to that data. That data is captured by Google of the world, Amazon of the world, the wearables, the Fitbit, and they're not going to easily give it away to whoever it wants. Like they treat it as their own assets, which is weird. But even if we solve that problem, then it goes back to what you were just saying, that what is the problem we want to solve? Is it to solve the longevity you live, or is it to solve the quality of life you're going to have, or is it trying to make you a stronger human? And I think these are the different offerings that different medical, if you call them medical businesses, they could offer. So somebody could look into make you have a healthier lifestyle, somebody else could look into make you live longer, and somebody else could come up with solving another problem. And it depends on people to who they want to use for what.
Absolutely. I mean, there's a pragmatism to this as well. So I think you mentioned cancer prevention, and cancer prevention is something that I think is probably quite a pragmatic approach, because people do get cancer quite often. So you don't have to look at data for too long to see answers. Something like lifespan or general wellness or quality of life. A, quality of life is hard to measure, and B, if you want to do lifespan, you need to follow people for a really long time. So I think any interventions in that space become a lot more complicated. So I think pragmatically, cancer prevention is probably more accessible. But you're right; it needs to be optimized for a particular question. There is, in fact, there is a big initiative.
Yeah, I was talking to somebody, and the way they were about longevity, and the way they were looking at it is, what is the most cause of death? Let's focus on solving that. You take that away, then something else will become the most cause of death, and you just fight those problems. And overall, that's going to make humans to live longer. But it doesn't necessarily solve the quality of your life. It just makes, it's like discovering, the antibiotics. People rarely now die from infection as much as they used to before antibiotics. So that removes that cause, and people live longer, but it doesn't mean they have a better quality of life in that.
Yes, yeah, absolutely. It's difficult. I guess there's a few things that we can probably agree on, and cancer prevention is probably quite a clear one, right? That nobody really wants to get cancer, and so building data sets optimized for that will help. And people are doing that. There's a Cancer Research UK a current project called Cancer Data-Driven Discovery that's trying to do exactly this. It's trying to pull together your hospital data, your GP data, your wearables data, whatever data it can get its hands on to give us the tools to be able to train our models on.
Mm-hmm.
For cancer.
Yeah, absolutely. And do you think then how much of it, because one of the other problems or unfortunate matters in the healthcare system is access to expertise and equipment and the medicine, the drugs, basically in different parts of the world. Access to those things are very, very different. Even within the same country, access is not the same. How much do you think AI could make it better or worse?
Yeah, so this is tricky, and I'm maybe a little bit skeptical about this. So I think I know when we talked before, you talked about access for underserved populations or rural populations or those sorts of things. And I think I haven't really. I'm not totally convinced about a clear AI approach that's going to do that. I mean, the one thing I could think of sort of tangibly would be in communication. If I write a jargon-laden letter, then theoretically, you could have some kind of chat GPT that you could talk to and explain it and get a better sense of what's going on. But ultimately, we already have the internet. I mean, I can already talk to people. I can already get them to send photos in. I can get AI to look at the photos, but that's there, that's done. And it doesn't really matter where they are sort of geographically for that. The risk and the flip side, so something we've had in cancer medicine is that when we do cancer sequencing, we do our genomic sequencing to know if there's a mutation in a cancer, we compare your genome to a reference genome. And traditionally, the original reference genomes, they're all from white Americans, right? And if you're not a white American, then you will get some spurious results. It will probably think you've got more mutations than in fact you do. And that's becoming more and more recognized feature, but it's still a problem. And we still have, that we still haven't completely cracked that problem. And I think that same problem applies to any AI. If you train it on your wealthy middle-class American population, it may not translate, and you may end up worsening your inequalities rather than making them better. I don't want to sound too glum about it. There's probably some hope in that. We need to be thinking about it, I think.
No, the silver lining of that is once we know how to fix or we know that exists and we want to fix it, we get behind fixing it, then fixing it is not necessarily a big problem. Say, for example, we don't have a lot of data on, I don't know, Middle Eastern women. Then we go capture data. We tell them, that part of the population, we don't have enough data about you, so you're not going to be able to do good diagnosis for you. And I'm sure, if somebody tells me that, I'll volunteer, come get as much data as you want from me. That would help, people like me to be helped. So I think it's about, again, goes back to the constraint of the sector, that is it's patient data. We don't have enough regulation around it, or we have too much regulation sometimes around it. How much data gets shared. You might, in the hospitals and in the research centers, you might not have a lot of data about Middle Eastern women, but Fitbit might have. They might be able to help.
True. In fact, I have seen a study that used exactly that. They used the kind of private genomic medicine to try and correct for some of those some of those changes. In fact, so our team have done a lot of work in lung cancer screening, trying to reduce inequalities, but it's quite old school the way that we're doing it. So it's been, I shouldn't take credit, there's others in the lab, but they've done things like developing, optimizing a leaflet so that we're not talking about a lung cancer check, we're talking about an MOT for your lungs, so people find it more accessible. And even in Manchester, there's teams driving the CT scanners to Tesco car parks, so that we're just making it more accessible, and we're making it, trying to get to communities much more directly. Honestly, I think that's going to make much more of a difference than AI. I struggle to see how AI is really going to fit into that pathway at this point, though that might change because it's a rapidly evolving space, as you well know.
Yeah, absolutely. And do you know what kind of AI has been used that has resulted in changes in the patient outcome? So, for example, the obvious one is image processing, and we have seen it in lots of different. We actually did a project for one of our clients who was basically, it's a lab that they do image processing to find the differentiators between the different time of the same scan, or the same area of the body's scan. So that's the most obvious use case in medicine, that the patients see the immediate benefit of the AI being used in medicine. What are the other
Yes,
examples that you can
though
come?
even that, I would say a lot of the data, what you would try to do with that really is about non-inferiority. It's not about doing something a radiologist can't do. It's largely about capacity, because particularly lung cancer screening is just approved in 2022, which means we're going to have thousands and thousands more scans, and we're just not set up to do that. So I think it's really about unlocking then the capacity of other staff to be able to do more and not burn out is
Which is very
important.
interesting, because when you want to change the culture from reactive to proactive, the amount of work that has to be done is so much more, because you're no longer scanning people who have symptoms. You're scanning everybody to see if they develop any kind of abnormality. So definitely the capacity and the scale at which we can do these things is really, really important.
Yes, it's critical for that kind of implementation. I think it's critical to have kind of a clear, but it's got to be evidence based as well. You've got to know what you're going to do with the results, and that can come into issues with something like an Apple Watch giving you notifications that you should get checked out or something. You need to know. You need to have pathways for that. You need to have protocols to know what to do.
Yeah, absolutely.
Evidence
There
based
are,
ones.
at the moment, there are some funny implications. I'm very interested in the human behavior and perception about technology generally. And I wear Whoop, which is a wearable that is not a watch; it just captures data, and it tells you if how long you have been in a stress zone in the past 24 hours, and shows you exactly when you have been and how much higher. And sometimes I'm looking at it, I'm like, that makes me stress. I don't want to know, like, why are you telling me? What do you want me to do with this information? This is just, this on its own sometimes is stressful. So really important to know, if you are telling, so if you tell somebody you look like to be heading towards having cancer, it's like, do you want them to know that, or
Yeah, it's a
you could do it in
huge
a
problem.
different way. Yeah.
Yeah, it's a huge problem. What do we do? How do we do that properly? And we're yes, I could talk about that all day. There's more. There's blood tests coming out that give you a risk of cancer, but again, if you have a positive blood test, that doesn't necessarily mean you've got cancer. It's just much more likely. But then that's not necessarily something you want to know if it's a false positive. So yes,
Yeah.
it's a real problem, the false positives with all of
Or what is
these tools.
is it 123 something, the company who takes your analyzes your gene and find out who are your relatives in the world, and that kind of stuff, and gives you like how much likely you're going to get Alzheimer, or based on your, well, I don't know how accurate those are, but that alone on its own is exactly what you're talking about. That if you tell me I have more more chance of getting Alzheimer because of whatever it's in my gene, then, and don't tell me what do I do with it, or there is nothing practical I can do about it. Well, I'd rather not know that, because if there's nothing for me to do, why would I want to know and be worried about it? So it's very much that interdisciplinary, that you can raise some stuff, but you can actually tell people what to do to impact.
Absolutely. I mean, you make the point. I guess what we're getting at is humans are terrible with risk, right? We're just terrible at it. And if you tell somebody they've got an extra, 20% chance of getting breast cancer or something like that, I mean, that you still don't have a very high chance of getting breast cancer. It's just a bit more than somebody else. And then, as you say, what's actionable? What can you actually do about it? But it can cause an awful lot of stress unless you
Yeah,
know what to do about
yeah,
it. Um,
yeah.
yes, I
And we
sequenced
know
my
how much
genome, but I kind of
behavioral
figured, yeah,
Yeah,
I
we know how
it
much
was.
behavioral science is uh, getting into the societal behavior based on these things. So imagine we start telling people those things, and then all of a sudden we have a societal issue because the level of anxiety of the society goes higher. So I think what we're getting into is whatever we do, and we will be using more AI in medicine, we need to think about the psychology side of it, because it shouldn't be like looked at from a geeky point of view. It's human behavior. So that, going back to the framework, whatever the offering of a business is, whatever problem they want to solve, the role of the human in the middle, I think it's to think that the person you're helping is a human, and humans are very unpredictable and very predictable at the same time, which makes them very difficult customer, basically.
Yes, yeah, absolutely. I think there will always remain a role for humans, for sure, in this particular space. Yes.
What do you see? Let's talk about the young people going to medicine. What would be the role of? So let's say let's go a bit to the future. Let's say like 10 years, 15 years. If somebody, because in medicine, if you want to get to the really top level, it would take you 10, 15 years, I assume. So if you're starting now, what kind of thing you can see? What kind of role you can
well,
see
I guess if I talk
you?
about I guess if I think about how I think things would change over the last sort of next few years, I think the first things we'll see are probably process changes. They're not the really exciting stuff. They're things just get a bit easier. And I've always been a big, UX is important, and most hospitals don't really understand that. But I think you'll start seeing it's easier to find the guidelines you need. It's easier to get the information you need about a patient. And if I pull up a patient record in the hospital, if they've been there for a month and every day they've seen 3 or 4 different members of staff and everybody's left a note, and most of them have said, introduced self to patient, I've covered myself by leaving a note, but I haven't really put much information in that. How do I get what I need? And patients all assume that I know everything about them, but I'm never going to get through all those notes, right? And I think tools like that can just make those things easier will be revolutionary. There are some great examples. I think just researching for this, actually, I noticed AWS have come up with a new tool to transcribe medical consults. So they're starting in America to be places where I can have a consultation and then I don't have to document it. I turn around and I've got a draft all there and all the blood results are pulled in, and that saves saves
Well,
hours.
Google,
it's half the time.
Yeah, I think Google last week they said they have released a new AI, medical specific AI that is doing better than GPs. Like on average, they're making diagnosis better than GPs. So we're going to see these things coming up. So if I was,
So
if
those
you
things
were,
I have I have a little more skepticism about that. And I guess what
well,
you're
I
getting
do
at
as
is, so
well. Like
I've started,
it's Google.
yeah, true. Well, I guess I'm starting with I start with the process things because I think they're things you can implement. All of those things aren't very difficult to implement. I mean, technically it's there and you just need somebody to get it into a patient system. What it doesn't need is clinical validation. What you're describing does need clinical validation. You can't have somebody giving you a diagnosis or giving you a clear direction of what you should do without putting that through a trial. So those things will come a few years later. And I think I've definitely experienced many times where you read the notes and you think, this patient looks fine. We should send them home. They look absolutely, there's nothing wrong with them. And then you see them and you think, oh God, I was really wrong. They look terrible. Like they're definitely staying. And the other way around as well. And I think there will definitely be things not captured in the data, and therefore, unless we've got really magical ways of filming patients or getting some of those kind of unrecognized insights that trained professionals have, I think just replacing staff in that way that the Google tool would try and do would be difficult.
I don't think anybody at least at this point is trying to completely change them. I think, or replace the GPs, if you say, but it's more about accessibility than, like, it's more about when you want to see a GP, you don't want to wait like 2 days before getting an appointment, and then all of those, like, I want to see a GP now. So if that provides enough accuracy and reliability to get, I think that's a massive improvement in the patient experience, that you get access to, maybe it's not the highest level of GP skills, but average I'm happy with, because you see an average GP. You don't go to the best GP of the world. You just go to whoever is given to you. You don't even have a choice. Who do you see?
You're absolutely right. As long as it's used appropriately, right? This always comes back to context, right? If you're, if you've got chest pains, you're in the wrong place. And actually, I'm maybe going slightly off on a tangent, but I think in terms of expectations, I think a lot of us have some experience of the chatbots that you get with, NHS chatbots that you put in your symptoms, and they're not very good. I mean, they generally tell you to go to A&E. So most people find them kind of a bit annoying and a bit frustrating, and it'll be a bit of a hurdle to say, try the Google one. It's better when people have that.
It's a very interesting concept, because it's all, even if the AI GP or even oncologist was really good, at the end of the day, it goes back to me as a patient, my perception of how good they are and how much I can trust them. So your experience with the patients, how much they trust technology to make any sort of decisions. So if you tell the patient that you're seeing, and it might be completely your perception, it's not like something you have necessarily done a research or statistics on, but like your perception, like if you go to the patient and say, well, I this radiology report is done by an AI, what do you think their reaction is?
Yeah, that's a difficult question to answer. I mean, I think people would have some faith in it. So I guess an example that I do would be these algorithmic but still computerized risk estimates, right? Where if I'm trying to say, should I give you chemotherapy, I'm going to use that tool to say, what's your risk that this thing's going to come back. People do trust that because it's built on data and it's what we have. Again, it's not quite making the decision, though, because even in that situation, I will have patients who think, do you know what, I'm going to take that risk because the chemo sounds awful, and others who say, I absolutely want you to try and do everything because I really don't want this coming back. So it'll come back to what it is you're trying to achieve and the decision you're trying to make, I think, and how big people see that decision as. You might be quite happy to take an AI report if it's saying everything's fine, carry on, go home. But if you're trying to decide on a chemo, you might want to be looked at again. If you see what I mean.
It's an interesting one, because I remember one time that I went to see a GP, and they to prescribe what they were going to prescribe, they looked at they Googled basically their database of like medicines and stuff like that. And at like for a moment I was like, what? Like the GP needs to Google? Like, are you serious? Like, so are you a competent? Like all of a sudden my brain went automatically into incompetence. Like, if it was a good GP, they should have known all of that. And then as I processed, I thought, actually I prefer them to search rather than try to remember what the dose or what, like, why we wouldn't have searches before. Why would people even try to remember what they like? Why would they even memorize that? So it's I think it's that shift of mindset of, maybe now we might be like, oh, I don't want your technology to tell, I want you or somebody really, really good to, with lots of experience, lots of years of whatever practice, to tell me what's best. But then maybe if we think a bit and look at AI as, well, if it has had so much data to draw something and it's assisting the oncologist or the GP or whoever to make a better decision, then we might start questioning why we wouldn't use this. Like, it should be used because it makes.
Well, but we're sort of differentiating there, though, between judgment and knowledge, I think, because I think, if my clinical judgment might be, you need an antibiotic, but then I might think, well, what antibiotic? Oh, I can't remember. What dose? Can't remember. I'll look that up. But that's fine to look that up. I think you still most people would want a clinician, I think, to make that decision that you need one. if you see what I mean.
Mm. And why do you think is that? Like, I'm trying to push a bit to get to the root of what is it that, like, is it really a role for human in medicine? And I'm not talking about the next few years, like that's not going to happen. But like, let's go to like 20 years. Why we would need a human to tell us what is wrong with us and how we can get better?
I guess it comes down to data capture. I mean, I think there's some things we capture really well, and there's some things we capture terribly. We can capture your movement and your heart rate and all those sorts of things, and that's fine. And there will be situations where I think, oh God, that heart rate's really high, and you've got a fever, and actually that data is enough to make a decision you ought to be on some kind of antibiotic. And then there are the much more difficult to capture things. Actually, there was a really good example where so when where we met at a dinner, and one of the other people at that dinner had this example of she was in A&E with her friend, and that friend was sitting there in pain, and she didn't quite understand why an AI system couldn't find the medication and bring her some pain relief and make that faster. And it I think is a great example of what we capture and what we can train against what we can't, because you can measure how long you're waiting in A&E. You can't really measure that you're in pain in that time very easily. It's very poorly measured. It's not really numerical in the same way. So I think that's where I'm sort of getting at, that you see a patient and you think there's information here that is not captured, and sometimes I'm not even sure how to capture it, but this patient looks sick. And maybe we'll get to a point where a video end of the bed sickogram kind of camera will look at somebody and get those inferences. But I think right now we're not there. I think the data capture is the missing piece.
I also think, given some of the studies on the placebo effect of doctors wearing white uniform, that you recognize them as being doctors, and not wearing it, and the impact of that on how people feel better. I think a big factor in wanting a human is that when you're sick, or you think you're sick, you're in your most vulnerable state, and you want a human who understands that vulnerability and who probably has experienced some sort of, so that's why they understand it, and that's why you connect with humans. And I think probably the part of the role of the human in the medical sector that it's very hard to replace, unless we create robots run by AI that create that kind of sense of I understand you, human. like I can connect with your vulnerability. I can give you a hug, kind of thing. I think that's the very, very unique impact, that regardless of how good people are in terms of their skill or expertise, if they're really good at connecting with the patient and reassure them that they're doing everything that is possible, that's when you value them the most. That's when you really see the value of having human. So I don't think we should, or we want. It might be possible to completely remove the human in, like, let's say hypothetically, in 30 years time.
So I guess all the talk about where the humans fit in brings us back to the question about what advice you'd give to somebody starting out, or somebody starting out in this space. And I think it's still a career worth going into, but I think things I would say is it's worth thinking more specifically within medicine about where the impact's going to fall. And we've talked a lot about things like radiology and pathology as well. These are still, I think, skills that are going to be essential, but they're going to change drastically and quite quickly. Whereas something like oncology, I'd argue, will change fast in terms of what drugs we've got available. I mean, we haven't really talked at all about the kind of drug development pipelines and another side of AI there. But whilst it will change, I guess the role of us as people delivering these drugs probably won't change as much as in other specialties. So be mindful of that as these technologies evolve. I would definitely advise to get stuck in and play with these things, and that doesn't necessarily mean you have to go off and do a computer science degree or anything like that. I think it's helpful to.
Well, you have to do a mathematics and work in aerospace before you get into.
Yeah, it's not a prerequisite for everyone, um, but embrace your geek for sure. Like it's good to at least see how these things work and see the limitations. So there's nothing wrong with asking ChatGPT what you should do about a patient, as long as you understand the limitations and don't act on it unless you're confident that it's giving you information that backs up guidelines and there's evidence backing up that basis. Um, and you can also really try to automate all the rubbish stuff about the job, right? So all of the stuff where you have to send off tickets asking for feedback and you have to summarize cases and put them in portfolios and stuff. All that stuff is just a drain on everybody. And if you can automate some of that stuff, I think that can be really helpful.
Wonderful. I think it's a good segue to concluding our episode. I was going to ask you, what would be your advice to the business leaders within the sector? That what do you expect them to do? What is the best thing they can do in the near future to make a biggest impact on the patient outcome and the life of the professionals in the medical sector?
Yeah, I'd say so. Two things I'd say. The first would be UX is important. Pay attention to it. Like, try and solve the problem, because a lot of what we talked about really comes back to, well, what problem are you really trying to solve? What are you trying to get to? And so, spending time with the people using all the systems that you've put in place already and understanding where the pain points are, a lot of them can be solved. And those UX things are quite achievable, and they're achievable quite quickly, like being able to get good summaries of notes, being able to speed up the documentation process. All that stuff would make massive difference, and then unlock the clinician potential to do so much more. And I think that doesn't require massive amounts of money in clinical trials to get that done. So I think I would pay attention to that early. And the other thing to really pay attention to is data, investing in the data that you have and in the structure of the data that you have. One of the issues I guess everybody has at the moment is somebody comes in with a diagnosis, any diagnosis, and we have teams that try and code that diagnosis and capture it. But it's a laborious process, and it's kind of a painful process, and it's not always accurate. And I think maybe one of the exciting and kind of not that well recognized applications of the generative AI tools we have is that we've got all of these unstructured data. We've got notes that aren't in any particular structure, and they have the potential to turn that into structured data that we can then use for the more traditional AI things. So we can use to train a model to do something good. So so I think my two things really, would be think about UI and UX, and invest in that data. Make sure you've got people who understand it.
Wonderful. And my final question, and you can refuse to answer it because it could be the whole podcast of its own. But what do you see AI in medicine being a revolution or an evolution? Are we going to evolve our medicine with AI, or it might be completely disrupted? And one of the examples is like if you end up, discovering like drugs that are very, very different in the way they treat, it could become a revolution. But
yes, now so you've asked a cancer biologist about evolution, right? Cancer evolves. It's like a big part of our science. So forgive me if I don't give you an entirely one-word answer. I would argue we've talked a bit about a big revolution in what we're trying to do, which is that shift to preventative healthcare. That is definitely a revolution because it's changing kind of the purpose of medicine. AI arguably is more of an evolution, but what it does is it really speeds up that process, and it gives you that diversity of different tools and it makes it so easy. I mean, I think any reasonably technically literate doctor can now tinker with these tools and try and make them better. Create a GPT that might help with guidelines or whatever. There's lots of tinkering that can be unlocked by these tools, and that gives the sort of substrate of diversity that allows evolution to flourish. So I would argue it's sort of evolutionary, but the chances of getting something revolutionary out of that mix are pretty high.
Okay, cool.
That's not a very straightforward answer.
Well, it's a difficult question. You can't have a one-word answer, but I think that was pretty cool. Thank you so much, Adam. It was wonderful to have you, and I look forward to see you more often and hear what AI is doing in the world of cancer research and what new things are happening in the near future.
Oh, well, thanks so much for having me. It's been fun. I hope to come back at some point.
Thank you.
Thanks for joining us in the Innovation Room.
We hope it sparks some ideas.
Want to learn more about what we do?
Maybe you could even be our next guest.
And spark some ideas yourself.
Find us at Geeks Limited,
And join us again soon.
because real change never stops.